You can't replace part of the brain. Like, you
treat them the same.
A source of truth for the medtech industry.
Coexists with the province.
Robot understands things automatically.
Number one show in the medtech industry.
So Stryker got ahead of that and changed in the 90s, built $1 billion company that held up high, a lot of things.
State of MedTech with your host, Omar and Khatib. Hey everybody, welcome back to the show. Today's guest comes from the world of stroke. We all know how many people are affected every single year from stroke. It's usually in the millions just here in the United States. I guarantee you, if you're listening to this, you probably have a family member who's been affected by stroke, or a friend or something else like that. It's a huge problem. StrokeDx came on my radar because they won the MedTech Innovator Award in 2023. A really great founder story. And so for that, I have their co-founder, Dr. Shane Shahrestani, joining us. Shane, thank you so much for joining us today. How are you doing?
Thanks so much for having me, Omar. I'm doing fantastic. How are you?
I'm doing great. Now, I love how you guys position the technology. At least when I read about it, it immediately made sense, which is kind of like a metal detector for your brain, specifically for stroke. We'll get into that in a little bit. But real quick, just for the clinicians who are listening, the audience, the investors, I want to ask you a little bit just on a high level. Tell us about your background. We talked about this off camera. You have really impressive pedigree, I got to say. So, and I have a lot of impressive people on the show. Tell us a little bit about your training and your background.
Yeah, of course. So the journey started at UCLA. I've always been interested in the brain. So there I was studying neuroscience, and it came time to choose my life path. I wanted to go into medicine. So from UCLA, I was applying into medical school. I basically got rejected everywhere, waitlisted everywhere. And then the last minute, I got pulled off the waitlist at USC to go meet insurance I needed. And I showed up at USC, just MD. And during that time between applications and transitioning to med school, I had done a lot more research, and I realized, hey, I really like the world of medical devices. This is where I can really make an impact. I feel like I have that creativity to be able to spin out something new that can help people in a positive way. So the big dilemma I had was, do I go the MBA route and learn how to manage a company, or do I go the PhD route and learn how to make devices from scratch? And as a medical student at USC, I applied into the MD PhD program, and USC's partnered with Caltech as well. So I got in and I was able to do my PhD at Caltech in medical devices, medical engineering. And really, when I showed up, I had never done engineering in my life. So I was in the MEMS lab, micro electromechanical systems, tiny, tiny electronics. And I learned of some circuits that they use in aerospace, actually, where they look for cracks in airplane wings. And it works a lot like a metal detector, like you mentioned. And I was thinking, hey, I'm interested in the brain. We got these cool circuits that has never been applied to medicine. How can I combine the two? I started designing experiments. I made benchtop models of the brain. I brought these sensors on. I redesigned them for a form factor that's more fitting for the human head. And lo and behold, they're able to find blood. Distribution to blood, specifically within the heart, which got me thinking, hey, in my first 2 years in medical school, before I transitioned to my PhD, how many stroke patients did I see who had a small exam change in the ICU that warranted a whole team of respiratory therapists and nurses to wheel an intubated patient down 4 floors to a CT scanner, where patients are the most vulnerable because they're alone in a scanner, and then wheel them back up with all these drips and the whole respiratory breathing machine? And how can we make this a more efficient experience for patients at the bedside? So then I started designing these new sensors, which is really how StrokeDx was born.
That's amazing. And what I love is, I personally really enjoy speaking to clinicians who saw the way that things are being done. The status quo in medicine across the board, there's so many things that are outdated. And I think now, because of technology and social media, you're exposed to other industries, and you kind of say like, oh, why is it done this way in medicine? For you, did you have something similar to that? Like what was going through your mind that moment that you were in the ICU and you were working on things where you're like, this actually doesn't make sense. Why are we doing this way? Was there something that inspired you, or you just, take us back to that day?
Yeah, of course. So as a medical student, you're really seeing everything with such a fresh perspective, and you don't know what the current paradigm really is. So if you have a creative mind, you can just start imagining, oh, well, if I see this problem, I can solve it this, and this way. But once you start learning the paradigms on what we do, you sort of fall into that routine, which is proven, it's published on, that's how we do it, that's the best way that we have available. But until you know the full paradigm, you really have a lot of ideas on how to improve it, is my perspective specifically. And in that moment, I didn't necessarily have an idea, but when I looked retrospectively as a PhD student, I remembered that moment in the ICU where people are just spending time wheeling people up and down, looking for resources, waiting for transport, waiting for the respiratory tech. And there has to be a better way, especially when time is brain in these stroke cases. Patients are laying in the hospital bed. Every minute, millions of neurons are dead irreversibly. So how can we expedite this whole process for patients to save brain and on the back end, just have better outcomes overall?
Totally, I love that. And yeah, even from my medical school time, some of the few quotes that I remember is "time is brain." So on the topic, let's kind of dive into it. So with stroke diagnosis, time is very critical, and with ischemic strokes, at least from what I remember, it's something like, I don't know, like 3 to 4.5, 5 hours that is when you really have to do treatment. So with StrokeDx's sensors, based on what I've seen on your website and your materials, is able to diagnose within 1 to 2.5 minutes. So that's a huge change. How does it work? Quick commercial break. If you're a medtech startup founder or an investor, I want you to think about something. Imagine a place where deals actually get done. You're not just getting lost in the chaos of a crowded convention hall. A place where it's a who's who of medtech, where the best minds are coming together, not just to network, but really shape the future. That to me is LSI. And in 2025, LSI USA is back. This past year, they brought over 1,500 executives from innovative companies, investment firms, venture capital, etc., all together. And they're doing it once again. From the investment side, they have people from family offices, global strategics, private equity firms, venture capital offices. And then from the startup side, especially spanning all kinds of exciting areas from cardiovascular to neurology to AI, robotics, and more. LSI is more than just a conference. It's a curated experience where real business takes place in a world-class venue, being the Waldorf Astoria in beautiful Dana Point, right on Monarch Beach. Now, why LSI? Well, they do things differently. For me, they're the epicenter of medtech, where they offer a platform for emerging leaders to present, pitch, and partner with the best. And with more top funds attending than ever before, LSI 2025 is going to be, in my opinion, probably the highest investor to attendee ratio yet, meaning more meaningful connections with venture capitalists, private equity firms, angel groups, and more. Plus, for nearly 2 decades, LSI has really been a cornerstone of the medtech ecosystem. Their events, market intelligence, and media reach have empowered leaders to make strategic decisions, drive innovation, and create better outcomes for patients around the world. It's more than just a conference. It's about challenging convention and catalyzing innovation. Plus, I got to give a shout out to the LSI team. Some of the best panels I've ever seen all happen at LSI. So if you want to make sure to secure your ticket, because again, this is a limited conference in a limited venue, go to lsiusasummit.com and immediately book your ticket. Go ahead and get your ticket. And if you're a startup CEO, I can't emphasize this enough. Your greatest ROI is probably going to come from applying to present, because you're going to get a beautifully produced video, a lot of exposure, and more importantly, the opportunity to refine your pitch. So go to lsiusasummit.com, and when I see you at the summit next year, be sure to say hi. Now, back to the show.
Yeah, that's a great point and really good memory from medical school. Yeah, 100%. So when you have an ischemic stroke, you have a limited time window in which you can give thrombolytics, drugs that dissolve the clot. And more recently, with more endovascular interventions, you still have a short window. It's longer than that, but still a short window where you can really make a difference by performing an intervention. That's in the world of ischemic stroke. In the world of hemorrhagic stroke, if you have a big bleed in the brain, you want to make sure your ambulance is going somewhere with neurosurgical capabilities. You may need an external ventricular drain, which is just a drain that they put in at bedside to help relieve the pressure on the brain. You may need an evacuation where they can take the bone out, either permanently or put it back to take that blood clot out. But you want to have those options available. And in the current state of stroke, especially in rural areas, people are directed to the nearest ambulatory center for triage, right? An urgent care center, an ambulatory care center in rural America is very different than being in metropolitan Los Angeles and having feeders and UCLA and USC all at your doorstep, and they have all the resources that you need, right? So getting to the right place is really important, and StrokeDx aims to make that difference with its novel technology. Specifically, as we mentioned, it works like a metal detector, and the idea is this. We have blood vessels in our brain that supply blood in a distribution that is unique to every single person. We have the same vessels basically, but they all course a little bit differently. So when you scan with the StrokeDx device, you can capture that distribution of blood within your brain or my brain or someone else's brain. Then when you scan again, you can compare to your own baseline over time and see how those signals are changing, especially in an ICU setting, right? Patients get medications all the time that change their mental status. Things for agitation that can make you more somnolent, steroids that can make you more agitated. And based off all these exam changes, nurses and physicians get worried and they order for these super stat CT scans, send them right now to the CT scanner because their exam changed, right? That introduces radiation and costs and the dangers of transport that you can avoid if you have some system at the bedside that is non-radiating, non-invasive. It can just move around the head in minutes and tell you, hey, the distribution of blood is similar. Things haven't really changed. It's probably from the medication, right? And if you do find something that's concerning, then you can expedite everything else because you'll have a high probability that something has changed.
Got it. And I'm wondering, for what you described, it seems like StrokeDx, the product, and I actually have it here on my screen. Let me bring it up just for the audience who's watching on Spotify or on YouTube, just to kind of put into context as to what it looks like. So it's obviously it's a handheld device. Let me scroll down here. That's sort of the breakup of the sensor. And for those who are interested, you can go to stroke-dx.com. So here it is. So this, it looks like there's a fiduciary marker that you put over the skull. Is that correct?
So these photos are a little outdated. Actually, what I'd like to show you is the automated device. I think if you scroll down a bit more, I think that guy might also pop up. Maybe you should go to the home.
Oh, let me go to the home. Yeah. Oh, that's a huge difference. That looks way cooler.
Yeah. So we're looking at right now, or my PhD work, right? And that's the initial rendering that we had.
This is ugly baby for Caltech, and then this is what happens when you raise an oversubscribed seed.
Exactly. This is exactly it. So we're really excited about this device because it's lightweight. It weighs about 10 pounds. Nurses can pick it up, put it right at the bedside, and lay patients into this head strap design with a neck brace. And then it has basically a bunch of robotic arms that pivot it around the head to every single angle and corner of the hemisphere of the head.
Hold on. I gotta interrupt right here. So you said robotic. I'm a robotics guy. That's how I started my career. I love robots. So, and I was gonna ask, so what's interesting is that if you look, your V1, right? Your MVP is essentially handheld. It's manual. You took the manual side out, so you kind of democratized this approach, and you created this. What part of this is robotic, and why do you need it to be robotic?
So the most important thing for physicians, right? If I'm telling you, hey, I want to replace a CT scanner, I want to give you a tool at the bedside so you don't have to go to the CT scanner, they're going to have a couple things they're going to ask of you, right? They're going to say, one, most importantly, can you find a stroke? Two, if you do find a signal change, is it ischemic or hemorrhagic? And we discussed the topic of metal detectors. Blood is ionic. If you have too much blood, like a hemorrhage, the signal goes up. If you have too little blood, like a ischemic stroke, the signal goes down. So we can do that. The next important thing is going to be location. Where is it located? You can imagine if you have a handheld device and you're moving around, you can capture location very broadly, but not very granularly. So the idea of transitioning to this automated device was to really, really improve location sensing abilities. And at the same time, having that really refined approach with the robotic arms gives you better volume approximations and depth approximations because it is so calculated and precise, right? So that is why we made that transition. This is our first device that we are pushing and we're really developing and taking it, in the next few months to the FDA, but we're still developing the handheld device. And especially over the last month or two, we have made strides in the handheld design, and we are basically using all math, no fiducials, no radiation, to be able to really accurately map out the geometry of the head and to just scan across the head, collect all that data, and just in real time populate where do we think a pathology is located. So that's still in the works.
That's amazing. That's amazing. And, for the audience, I kind of skipped over one because I'm pretty excited about the technology. But let me kind of just for context, for those, we have a lot of family offices and everything that are not used to healthcare. So let me just show real quick what current stroke care looks like. Ambulance picks you up, takes you to a center, and they put you in a very large machine, which is a CT scan. As you can see, these things are really big. And so the likelihood that you have multiple of these is not high unless you're in a big center. But in any case, you have, somebody that goes behind a glass door to run the machine. And so it's quite cumbersome versus what's unique about yours is what I just showed doesn't look like it's for an acute setting, but it is, right? Your device is designed for an acute setting, meaning that, hey, somebody has a stroke, you have, max 2 to 3 hours where you have to get them a scan to figure out what you do next, right? And so your device, hypothetically, and let's imagine that you're in a rural area, like how long is it going to take for somebody to pick you up from the ambulance and take you to the hospital, etc. Your device can essentially sit in an ambulance. Is that correct? Am I kind of jumping ahead? Am I correct in that thought?
Yes, the thought is correct. The reason we have two different devices is based off the specific hospital setting where we want it to be. So the bigger automated one, I guess taking a step back, the space in an ambulance, the real estate is very limited, right? So when you talk about giving a device to an ambulance, it has to be tiny. It really should not be burdensome to everyone in the ambulance, and the device is already existing in there. So the 10-pound device that sits at the head of the bed, that's for the inpatient setting. That's where we're designing it for. But the handheld, as we mentioned, we're still refining it. That is going to end up in more of an ambulatory setting. You can think of it as like an ambulance or an urgent care center or in the emergency department as soon as you step foot into the hospital.
Got it. And I do like that you guys have thought through that, because sometimes I feel like, at least in medicine, do you feel that sometimes because you have a background in device development, do you feel like sometimes devices are developed without taking into consideration the real estate of the environment that device needs to live?
100%. And the most important thing at the end of the day is human factors and usability. Because if you don't design for those, nurses don't want it, doctors don't want it. It's just not going to fit in the room.
For the non-tech audience, when you say human factors, can you explain what that means?
Of course. So any device that you have in the hospital and the ambulance, someone's going to have to use it, right? And when you look at all the different personnel that you have, you can approach it a few different ways. One, you can have dedicated techs, like an X-ray tech, for example, that will wheel an X-ray machine around the hospital and go to all the patient rooms where X-rays are ordered. But then you can also have nursing, who already has such a busy job and they're taking care of multiple patients usually. So you don't really want to burden them with a big bulky device and train them on how to use it and how to be very complicated. That's just going to be a time sink for them and they're not going to want to use it. Right. So the goal is to find a balance, to find something that sits in the room, doesn't take up too much real estate, is easy to use, so people don't have to spend too much time training and using it for the multiple sick patients that they're responsible for.
Got it. And that makes complete sense. Something I wanted to sort of pivot to and ask you about, by the way, is, there are companies, one very successful one, I don't want to mention company names, but like one that is a startup, they're actually they announced they'll be doing an IPO soon, that are point of care EEG devices. Is StrokeDx considered a point of care EEG device? And if not, what would you consider? What's the category it falls into?
So the exciting but also extremely difficult thing that we're doing is we're creating a new category. We're not EEG, we're not ultrasound, we're not infrared, we're not microwaves or a high energy emission system, and we're not traditional, CT, and we're not traditional MRI either. Really what we're doing is using what we call ebb currents, this really, really weak magnetic fields that have transient signal changes that we can record that are proportional to the target that you're looking at and how electrically conductive it is, basically, right? So that goes back to working like a metal detector. You can imagine you're walking over a beach, it's all sand, and then you hit this really metallic gold necklace that's hidden deep in the sand. That's the signal change that you're picking up. Now you can imagine redesigning that whole system for human tissue. That's who we are.
Got it. Understood. That makes sense. So, okay, if what you guys, at least from an analogy standpoint, are essentially a metal detector finding like gold in the sand, if that's the analogy for StrokeDx, for these point of care EEG devices, just for the audience, like what analogy would those fall into technically?
That one is more like you're sitting on the beach and you're listening to the waves, and every wave should have a characteristic sound. And then all of a sudden you hear this really different crafting sound in the waves. And that could point towards something being wrong or something changing, right? And that's more of an EEG analogy.
Got it. Now between let's say an EEG and CT, right now for diagnosing stroke, what is the current standard of care and why?
Right now, for the current standard of care for stroke, CT is the first go-to for hemorrhagic, for bleeds. MRI is the golden standard for ischemic stroke.
Got it. But of course, I guess the limiting factor there is that MRI, I mean, aside from very big, it's very expensive, et cetera, et cetera.
Very expensive. And touching a little bit on the costs, with the Affordable Care Act, stroke itself is 10 to 20K, right? It's usually right in the middle, about 15K per patient per stroke in the hospital, right? So when hospitals get this bundle, they basically have to spend it wisely on the patient to provide excellent care. But at the end of the day, hospitals want to have some of that money for themselves, to pay their physicians, to pay the staff, and just for the hospital itself, right? For providing these services. Stroke year after year has been negative in the US healthcare system because of the number of resources that patients require in order to provide adequate care. every single time a patient goes back to imaging, you're spending $2,000 to $3,000 just on that one episode. And you can imagine it can be more if someone's intubated and requires multiple drips and they require multiple personnel to take them down safely, right? So the idea is, because stroke is so costly, if we can provide some sort of device at the head of the bed that can provide real-time data to physicians and to nurses, you can avoid these time sinks, save brain, have better outcomes, and on the back end, save money for the whole healthcare system and for hospitals, healthcare networks, and physicians, right? So it's sort of a win-win-win-win, where patients have better outcomes and the cost savings for the hospital make more sense, right? So that's the approach that we're trying to take as we develop our device and work through all the human factors, all the other factors that determine where it's specifically placed in the stroke analysis paradigm.
Understood. And it makes sense based on what you said in terms of what the value proposition for the hospital. The table stakes are always either you're going to help the hospital make more money, but most often it's going to be saving money. So I understand that side. And of course, the value to the patient in terms of time to value. You shortcut your way to save a lot of time to ensure that the patient is safe and treated. What about, for the investor's perspective, what's the business model for StrokeDx? Because you guys, this technically qualifies as capital equipment. And so what's the business model? How do you guys essentially make money?
Yeah. So it's actually really interesting and really unique. The first device that you showed on the podcast, the prototype at Caltech, that cost us less than $100 to make. And we were able to scan patients. Those are amazing pods. So we will scan patients at USC and have really good data that we published in a really high tier journal, one of the Nature journals, and showed that this is feasible and it works, right? Since then, obviously, as you make the device more complex, you invest money into it, you have robotic aspects of it that require motors. It gets a bit more expensive, but nowhere near the cost of CT or MRI, or even some of the other competitors in the space, right? Having this device, the capital equipment, be deployed to multiple different hospitals at a reasonable cost helps us get our foot in the door in multiple places. And we're going to have, in addition to the capital equipment, disposable element, which is going to be per patient use, similar to some of the other equipment you can see in the ICU. For example, there's pupillometers that you can look in every patient's eye in a nice new setting, and each of them have a patient-specific disposable attachment, right? It's going to follow some of the similar models of devices that have come before us in acute care, ICU, and inpatient settings, right? So that's really what we're looking at in terms of the next steps as we deploy the device out.
Got it. And then just on the product roadmap, there is a growing need and desire for a lot of companies to digitize their devices and collect data. I can see some use cases here for machine learning and AI applications and capturing data. Do you guys have any software? Do you have any plans for that? How are you guys thinking about this?
Yeah, it's a fantastic question. So as we initially start, the device will be more tuned for monitoring. And like we described, it's going to pick up Shane or Omar's specific head signature and then track that over time in patient setting, right? But as we collect more data, then it becomes possible to refine the algorithm to become a primary diagnostic or detection algorithm, where you scan someone at the point of care and then right there in real time say, is it ischemic? Is it hemorrhagic? Where is it on the brain? How big is it? And then do everything else, right? So our first step is going to be monitoring, and that's really what we're focusing on now. But as we move into the future, all that big data, AI, ML techniques will come into play.
Got it. Fantastic. The other thing really exciting technology. Where are you guys technically in your regulatory pathway? What does that look like? When do you think you're going to be like at least maybe not commercial, but probably the next step would be like limited commercial release or limited market release?
Yeah, we've had multiple productive pre-submission meetings with the FDA, and our goal is to have our regulatory clearance mid 2025 for the automated device specifically. So right now we're doing a big push on our end to wrap up all the experiments that we have in progress to deliver a really pretty package to the FDA, so that we can hopefully stay on target for mid next year.
Fantastic. And so, you guys had a very successful oversubscribed seed round. A lot of the money, I'm guessing, is going towards that. Are you guys currently raising? And then, like, in terms of your next inflection point, like, is a lot of the capital that you want to raise specifically on just commercialization, or how are you guys looking at it?
Yeah. So, with this past round that was in May of this year, we expect that funding to take us through FDA clearance, and then our next fundraising will likely be post FDA clearance end of next year. All right, so we're good to go for the next year and a half or so, but it really depends on how fast we want to move. And I definitely want to give a big shout out to our team, especially Alex Ballatori, our CEO, who has really been crafting the vision for the next steps, especially on the business and fundraising aspects. He really has a knack for that, and he's one of my best friends. We actually met in medical school. I was his first roommate when he started medical school, and it just happened that chance. And it's been such a pleasure to work with such a close friend and brother, really, as we develop this device. So I got to give a big shout out to him. He's been really crafting the vision on the next steps.
That's awesome. I love hearing stories like that. I've personally become a big fan, just, not just from the technology standpoint, but, the founder story is really interesting to me. And I've really enjoyed following you guys along, and I'm excited we were able to get you on the show. And, for those who are interested, if you're an investor or clinician and you want to learn more about the company, go to StrokeDx or Stroke-DS. That's STROKE dash or hyphen DX.com to learn more. And of course, you guys are active on links, so you can look it up there. But Shane, just as we kind of wrap up, because of your unique background, you're a founder, everything, there's sometimes I do have these rapid fire questions I love to ask. And so if you don't mind, let's do some rapid fire questions. You can take as long as you want to answer these or as short as you want, and we'll get through it.
Let's do it.
All right, perfect. So the first thing is that, being a medical student and a clinician, the idea of continuing education is really big. Mentorship is really big. What's the most painful thing? It doesn't have to be a medical school. It could be a parent thing. What's the most painful thing that a mentor has told you or somebody has told you that forced you to change for the better?
That is a fantastic question. Not specifically in med school, actually. Before that, I've been told to follow basically the footsteps that have been laid ahead of me, right? And to me, that's really painful because I'm the type of person who really like to push boundaries. I really like to just see how far I can go, take ideas and see what I can do with them. Following a cookie cutter, a preset path is super, super painful for me. So I definitely did not take that advice. StrokeDx is the opposite of that advice. We really took a big risk trying to disrupt the stroke paradigm, basically. But we're very, very happy with what we're doing, and we are confident that the device that we're building is going to change a lot of lives.
Love that. All right, next question for you is continuing education, of course, is big. As you can see, I'm in my library. I'm sure that you read a lot. What are some books that, we'll say like 2 to 3 books that influenced you as a founder, as a creator, as an inventor?
100%. One of my favorite books of all time is Outliers. Have you had a chance to read that one? Malcolm Gladwell?
Oh yeah, By Malcolm Gladwell. Yeah.
Yeah, that's a fantastic book. I read that a couple of years ago, and it really changed my perspective on how I do things. Everything's set in a pattern. Everything is sort of predestined in a weird way based on everything that has preceded it and everything that has followed it. So that really changed my perspective and has inspired me to look historically on patterns of companies that I want to emulate, people I want to be like, physicians that I want as mentors, for example, and has really shaped my path as I move into the future. That's a fantastic book. The next book is The Lean Startup, I believe it's called. That's a book that I read as we were trying to found StrokeDx, and both Alex and I had no experience with any business in the past. So that was sort of our beginner's guide to how to start a startup. And the third book I want to throw in there is it's a neurosurgical textbook called Greenberg. It's something that I carry in my pocket at the hospital. And it's a book that basically outlines all the paradigms, neuroanatomy, everything that we do in neurosurgery and neurocritical care. So those are probably the top 3 books I'd like to shout out in this podcast.
Oh, I love that. And there, I'm a lover, of just collecting books and everything. And, at least from medical school, some of my favorite books, these pocket guides that are created are so beautiful because they do such a good job of simplifying very complex information, using right diagrams and everything to the point that it can just fit in your scrub pocket or white coat. I just love those books. So I'm gonna have to buy that book just to throw it in my library.
This one you really have to just shove in your white coat pocket because it is like 1,200 pages. But anything can be portable if you make it portable.
Yeah, there we go. 100%. Well, Shane, I want to thank you for coming on the show. We're super excited for you guys, and I'm going to be following along and watching you guys a lot. Again, for those who are interested, go to stroke-dx.com to learn more. I'm your host, Omar Khatib, and we'll see you all next time. Thanks for checking out this episode. If you want to do me a big favor and join so many other people who have helped grow this podcast, take a second and look below. If you're on Apple, give us 5 stars and write a short review. If you're on Spotify, just give us 5 stars. And if you're on YouTube, hit the like button. And most importantly, if you can, subscribe. We release so many different episodes that you may miss. Be sure to subscribe and turn your notifications on. You get extra points with me if you subscribe across all 3 channels. Thank you so much. And if you felt like this episode helped you, send this to somebody who'd really enjoy and appreciate it. Share and spread the love. We'll see you all next time.